Exactly 8 o'clock. Bismillah ar-Rahman ar-Rahim. Salatu wassalam ala Rasulullah. Good evening, everybody. My name is Dr. Khaled Alassiri. I'm a consultant orthopedic and spine surgeon. I am the chairman of the CPD Committee in the Saudi Spine Society, and I will be your moderator for the webinar today. It's our honor today to start the first webinar of the Saudi Spine Society organized by the CPD Committee. Today, the topic will be about the evidence-based spine practice, and will be presented by Dr. Sohail Bajammal. Dr. Sohail Bajammal is Assistant Professor of Orthopedic and Spine Surgery in the University of Umm Al-Qura, and he is the Vice President of the Saudi Spine Society. Just for general information for the attendee, please, if you have any question, you have to write the question on the message box down there, which I will receive. Then by the end of the presentation, we're gonna discuss it with our presenter. In case if we have time, we can take some question, audio question, and the audio question will be taken by order when you raise your hand, if we have time for that. We need to, I will tell you again, all of you, in the first webinar of the Saudi Spine Society, and welcome our speaker, Dr. Sohail Bajammal. I give him the microphone, and I wish you a pleasant presentation and pleasant evening. Dr. Sohail, the microphone is for you. I'll give you now in a minute.
Assalamu alaikum. Thank you very much, Dr. Khaled. It's really great to be with you in this webinar and to make history for the Saudi Spine Society, starting the first webinar, and hopefully with more webinars coming along the line. I think the CPD really is doing an amazing job at multiple aspects, and starting these webinars is really great, especially with this topic, evidence-based practice. So we'll start with the presentation. Hopefully you're seeing my screen right now. Thank you for the introduction, Dr. Khaled, and the topic that we'll be covering, as it was mentioned in the webinar, in the poster for the webinar, we're going to go to the introduction of evidence-based practice. So what are the major components of evidence-based practice? Why is it important? What are the steps involved in practicing evidence-based healthcare? And then we'll go briefly over the 6S resources of evidence-based practice and how to utilize them. And then I will conclude with what has the Saudi Spine Society done so far in this area, and how we are proposing to promote the evidence-based spine practice. So the term evidence-based medicine goes back to the early 90s at McMaster University, where it started at internal medicine residency program with Gordon Guyatt. And this was the initial definition. It's the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of patients. Now, what happened over the past few years is people got confused between, especially here locally, they would say evidence-based medicine and research interchangeably. I just wanted to make this clear as we start that doing research is concerned with research methodology, while using research is concerned with evidence-based medicine. The movement or the pendulum of evidence-based practice has went through lots of evolution. When it first started in the early 90s, it was that quotation of new approach to practice, and the focus was mainly around the research evidence. As years passed by, more clinical contexts were added to the Sorry.
I think you lost the screen. Is that right?
Sorry?
Just make the presentation. I cannot see the presentation. Sorry for the interruption. Yeah, it's okay back.
Do I need to repeat the... Were you seeing the previous screens?
We just lost you for 2 seconds only.
Okay. Okay. So the initial definition of evidence-based practice was focusing mainly on research evidence, and then as we moved on in the mid-90s, they added the clinical expertise, and they added the clinical expertise and patient preferences. In the early 2000s, more wider inclusion or wider components of evidence-based practice, as they added the clinical state and circumstances, the patient preferences, and the research evidence. Adding to that, combining all of that, is the clinical expertise. And then the most recent version of evidence-based practice, which is in the mid-2000s, and it stays till now, it combines the research evidence, the clinical state, settings, circumstances, with the patient preferences, as well as the healthcare resources. All of these are added together and combined with the clinical expertise. Now, what does that all mean? What do we need? Why do we need to bother about evidence-based practice? In our practice, we always ask questions. There are different kinds of questions that's being asked by all of us, and this includes. Just a second, I'm having a bit of delay here. And this includes what we call it background questions, and that's around etiology of disease, differential diagnosis, pathophysiology, and these could be easily found in textbooks. On the other hand, foreground questions deals with which is better for my patient, what treatment options are better for my patients, what options are less harmful, how can I diagnose this patient better compared to one diagnostic modality versus the other. As you can see here, the background questions, you can find them easily in textbooks. However, the foreground questions, that's where the bulk of our presentation today is around evidence-based practice and how can we find the best available evidence. So we have always grown up on textbooks. What's wrong with textbooks? Why can we find foreground questions on textbooks? The problem, they are great for background questions, for theory, for principles and facts, but their problem is they're usually single-authored chapters. There are potential of bias because it's author opinions, and they are usually not peer-reviewed. Another problem is they get delayed. When you develop a textbook, it goes through a lots of process of editing and formatting and what have you, and that will take up to a couple of years to finalize the process of publishing a textbook. So why it's important? Because, as I mentioned, the background and foreground questions, we deal on a daily basis with continuously evolving questions that we don't have answer to. And there are a huge information overload with large number of publications per year, which puts a pressure on the healthcare providers. Are all of these publications of good quality? Can we keep with the pace of this information? And how can we affect the care of our patients? One last very important point is, as you all know, we're going through transformation in our healthcare, and this transformation is concerned with value-based healthcare. And what do we mean by value-based healthcare? We mean that in the future, any budgets allocated to hospital or any payment allocated to hospital healthcare providers will be based on the clinical outcomes of the disease, the clinical outcome of the condition treated, and that's divided by the cost of that treatment. So this gives us the equation of cost effectiveness or value-based healthcare. And in order to provide high quality care, you need to make sure that whatever intervention, whatever treatment, whatever medications, whatever surgery you are offering is according to the best available evidence and it's cost effective. If we move on, now we have identified some of the key points of the importance. If we move on into how can we practice evidence-based, we start very simple. We start with asking a question, acquiring or collecting the information, searching and finding the information, doing a critical appraisal, and then applying the information to your patient care, and then acting upon that. So after you apply this new evidence-based practice, you see, is it really working? Do you need to change anything? Does it work in your local context or not? We'll start with asking a question. It might sound very easy, but in many courses for EBM or research methodology, they will dedicate an hour or so for just asking questions. They will dedicate a workshop for that as well. So just as an example here, if we have this question, what's the best treatment of acute back pain? Is this a good question? I guess the way I'm asking it, it's not a good question because it does not contain what we call it the PICO abbreviation. Any question that you ask has to contain the population, intervention, control, and outcome in order to be a good answerable question. And the same thing applies for research questions as well. So look at this question. In adult patients younger than 50 years old with acute back pain, does physiotherapy reduce the risk of recurrence of pain within 1 year compared to bed rest? So this is an ideal question because it contains population, it contains the intervention, it contains the control, as well as the outcome. So this is how ideally we like to phrase our questions when we implementing evidence-based and before we go to the next step of searching the evidence. Now you have had a question in mind, you ask it. The second point will go into acquiring it and looking for resources for studies, resources for systematic reviews, what have you. We'll go through these steps. And this is, I think, one of the most important slides in this webinar, the 6S model of evidence. This was published in 2009, and it's a continuous evolution of different models of resources. If you see at the bottom of the pyramid, you have the studies, and that includes case reports, case control, cohorts, randomized trials, all the types of studies that you are aware of. And then as you move along the pyramid, there are synopses of studies, and these basically are summaries, critical appraised summaries, and some journals, they publish them. And then when you go to the next step, which is synthesis, and they consist of systematic reviews and meta-analysis. And the synopsis, the similar concept, it's critically appraised systematic reviews, and they're published in either journals or in the database of abstracts. You will appreciate these concepts as we will explain them one by one in the coming few slides. And then at the top of the pyramid comes the evidence-based clinical practice guidelines, and really at the tip is the computerized decision support systems. There is a concept called the primary sources and the secondary sources. Or the primary sources is studies that clinical researchers published, and that's at the bottom of the pyramid. The secondary sources are actually work done for you. They have been processed, appraised, analyzed, and then presented to you as a healthcare provider in an understandable, easily digestible format. And the bulk of our presentation is talking about the secondary sources. And I will tell you why we want to focus on secondary sources, especially if you are not very interested in going into the deep technicality of evidence-based practice, and that's the reason why we're doing it. Original articles, you search within databases like Medline and Embase using different softwares or browsers like the PubMed or Ovid. In order to base your decision on primary sources, if you say, okay, I found a randomized controlled trials, you need to retrieve the full text, you need to appraise the study, and then you need to evaluate the possibility of bias starting. This is another very popular pyramid, starting from the bottom of the pyramid all the way up to level 1 evidence, which is randomized, high quality randomized controlled trials. Now, where to search? Where can you search? Very commonly, people would say, will Google it. Here I'm giving a couple of examples. I'm using the same phrase, acute low back pain. I'm using the same phrase of acute back pain. If you see here in Google, if you put acute low back pain, you will find 151 million results. Okay, it's great, it's very comprehensive, but it's not practical, because what will happen, you'll go through the first 1 or 2 pages, and then you will find something interesting, and that's it. The second possibilities that people search are Google Scholar. Okay, the Google Scholar, it's the academic version of Google. Google Scholar is the academic version of Google, and this is an example of acute low back pain. When I put it in Google Scholar, it gave me results of 2.5 million search results. Again, this is a huge number that it's not practical for you as a healthcare providers to go over 2.5 million results on acute low back pain. I know that I've used a very generic term, and there is a reason for that, that I've used this generic term to make it relevant for all the audience. Some of us are surgeons, some of us are, there are medical students attending, there are people from different backgrounds attending, so I made it very, very broad term, search term. Now, PubMed, people are sometimes afraid or not comfortable of PubMed. What I recommend is, if you go and visit pubmed.gov, the first thing to go is to visit the tutorials, the frequently asked questions. They have great tutorials. Each tutorial lasts 1 or 2 minutes, and they are great. I can assure you that within an hour of going through these materials, you'll be very comfortable with PubMed. Let's take the same example of having the PubMed instead of searching Google and Google Scholar, let's search on PubMed. What would be the results? The same acute low back pain will have 3,300, which is more manageable than 151 million search results. Okay. I mentioned that I wanted to be very broad, but this just to give you an example of some of the features in PubMed. You can add more limiting key terms, like here I use trauma. If you notice there, the or in capital, and that's how PubMed understand your search terms. When you are putting search terms, you have to put the or in capital. And if you notice as well, I put them between brackets because I'm asking PubMed to find any article that have mentioned the word acute low back pain and has mentioned the word trauma or fracture or injury. There's another point that I want you to notice, that I've used the asterisk after the fracture and after injury. And the reason for that, it will show me any article that included fractures or fracture, and it will show any results, any abstract that have the word injuries, injury, injured, all the different forms or abbreviation of injuries. Now, I told you earlier that the best or the most important slide was that the 6S pyramid. I think the second most important slide is this clinical queries, and this is a great tool for busy clinician to use, and I will show you why now. If you use the PubMed clinical queries, you go to the main page, you click on the clinical queries, and then if we insert the word acute low back pain and choosing the category we are interested in therapy. Therapy means different types of treatment. So it's an article addressing therapy mainly. You see how the number went down from 3,000 to 1,400 because this is a built-in search search terms by PubMed. It's done for you, work done for you very, very nicely and very easy. If we even go further and we use therapy with an arrow, that even narrow it down to 427 articles. 427 articles. And these are very narrowly search results focusing mainly on therapy, which means that there is a possibility that you might miss some of the answers at the expense of having manageable number of search results. Now, you went through the 400 studies, and you know that you need to pick up a randomized control trial for your specific questions, and you find this number 3 or number 4. It's a recent randomized control trials, and it's comparing intensive patient education versus placebo on acute low back pain. Okay, so you can't just start implementing whatever the conclusion of the abstract is recommending. You need to do critical appraisal. And how do you do, or what do you mean by critical appraisal? Basically, critical appraisal, you are looking at the article and you are saying, is this article valid? Is it trustworthy? Was there all the potential biases in the study has been addressed by the design? And then you need to assess as well how significant are these results. Are they only statistically significant, or they are really clinically significant? How can you generalize the results of that study into your population? So all of that, which we call it critical appraisal. And there are lots of workshops out there, 2 to 3 days workshops going through the details of critical appraisal and how to do critical appraisal. What I recommend as a starter is to go to the Center for Evidence-Based Medicine. It's by the Oxford University. It's a great tool, and it takes you through the process of critical appraisal. There are lots of worksheets there that you can download and practice doing some critical appraisal. And these worksheets are great because they are self-explanatory. But in summary, the critical appraisal goes through 3 groups of questions. The first group of questions, you're asking about, is the study valid? And there are maybe 5, 6, or 8 questions within this group of questions. And similarly, are the results important? Are they, how can I apply to my patient, or can I apply to my patient? One of the things that the Saudi Spine Society did last year during our first international conference, we did a combined course with the North American Spine Society. We did the hybrid course on evidence-based medicine online training, and we are repeating that again this year with a total of probably 100 participants in these courses. If you are interested even more to be exposed to critical appraisal and to be expert in critical appraisal, these 2 books are great. One of them on the left side is Essentials of Evidence-Based Clinical Practice. It's a smaller version of the book. The one on the right is a bit bigger, Manual for Evidence-Based Practice. One of these would be a great start for you if you want to really go deep into the critical appraisal concepts. Now, the challenge so far, what we have said so far, probably some of you would say, oh my God, this is too much, this is time consuming, and it is time consuming, it is very demanding, and that has resulted of some people actually avoiding the whole concept of evidence-based medicine, because that happened with the term called satisficing, and that means you're busy, you'll do a search, quick search, and then you will find a couple of articles. You'll be satisfied with the first or 2 articles, but there are risks that you might be sacrificing more comprehensive, bigger view of the topic. So what's the solution for that? The solution is the second step, the synopsis of studies. Many journals like the JBJS and Orthopedic and many other journals, they publish they call it evidence-based review. So every issue, there is 1 or 2 articles that they will do critical appraisal for them on your behalf. Very important articles. The next step, or the key, I would say, the key resource for evidence-based is the systematic reviews and meta-analysis. And what does the systematic review and meta-analysis mean? Basically, the authors of a systematic review meta-analysis, they have done the work for you. They have asked a good focus speaker question. They have searched the literature very comprehensively and very systematically. They have identified and selected the studies in a very systematic, transparent way. And then even they did the critical appraisal and they assessed the quality of the studies. So this is simply a systematic review. It's not rocket science. It's basically going through these steps in a very methodological and systematic way. If they add to that statistical combination, then that's called meta-analysis, okay? We go back to our clinical queries, the magic clinical queries. In the same screen, in the clinical queries, the same screen, if you put acute low back pain, you will find the results, interestingly, the results of 140 systematic reviews. If you remember, we started with 150 million in Google, 3,000 in PubMed, and if we're looking for systematic review, it's 140. And even if you are looking for something specific like discectomy or exercise, I would guess that this systematic review, the number will be much less than 140. Okay, so now you've had a list of 140 systematic reviews. You pick one of them. You pick one of them, and I will show you here an example of a meta-analysis. This was published in JAMA, and it talks about spinal manipulative therapy for acute low back pain. It's a systematic review. It's a great meta-analysis, was published in JAMA, and this is to show you how helpful a systematic review. In a systematic review, you will find the detailed search strategy. An example, this is just one example of their search strategy in PubMed or in Ovid. They have 37 keywords to find different articles for you. Different keywords are used for different databases. For Embase, they will use different databases and so on. And they publish it there. When they publish the systematic review, they will attach that with it to ensure the transparency. And what's even further more interesting and more transparent is they will show you, based on these terms, we found so and so numbers, and we started excluding them one by one because they don't fit our inclusion-exclusion criteria. Most of systematic reviews and meta-analysis have supplements like this great detailed table of critical appraisal and assessing the quality of different randomized control trials. Just imagine that if there are no systematic reviews, then you have to do all of this exercise by yourself. You have to go through all of these articles and review them and analyze them. They have done all of that work for you. And so far, that was a systematic review. If we add statistical pooling, as you can see here on the screen, which is called the forest plot, this is a meta-analysis where it's a statistical way. It's not only adding studies together. There are specific programs for that to do the statistical pooling of studies together to come up with a summary pooled estimate of the outcome measures that you are interested in. Now, are all systematic reviews good? I guess the answer is you still have to do appraisal of quality, the quality of systematic reviews and meta-analysis. And the same Center for Evidence-Based Medicine, they have a great worksheet on critical appraisal of systematic review, these 4 pages. And I would highly recommend as a starter to start with the systematic review, because that's the more convenient for you. That's more practical for you. You might, when you go through the critical appraisal of systematic review, you might come across some of the terms that you are not familiar with. That's fine, but you can go on and search these terms. what I would recommend, you go to the website, download these worksheets, and just pick any systematic reviews and go through them. The worksheets are very self-explanatory. If you see on each of these sheets on the left side, it will ask the question and then will tell you what's the best practice in doing a systematic review. And then it will even tell you where do you find the information, that specific information. So it's a very self-explanatory. There are many types of critical appraisal sheet. You can even develop your own critical appraisal sheet. There is no harm with that, and that's even encouraged. But this is some of the very popular appraisal sheet out there. Now, we've talked about systematic reviews and meta-analysis, and I've told you that it's. I highly recommend that you start with these skills of critical appraisal or systematic reviews, because it's much easier to start with compared to critical appraisal of randomized trials or cohort or the other kinds of studies. So what do you mean by summaries or evidence-based textbooks? I guess most of you are aware of UpToDate. It's an evidence-based textbook that's continuously updated, and I will show you some screenshots of that. And the jewel of all the evidence-based practice, or the most comprehensive resource, is the clinical practice guidelines. And they're usually done by independent societies or research centers, and they ask specific clinical questions, but usually it's broader than a single systematic review. For example, in a systematic review, they will ask a question, does exercise versus medication improve outcome of clinical of acute low back pain? And that's the typical question of a systematic review. On the other hand, for clinical practice guidelines, it's usually broader. For example, acute low back pain diagnosis and management, or acute low back pain diagnosis. And then within that clinical practice guidelines, there will be specific clinical questions, 3, 4, or maybe 10, and they will do a comprehensive literature search. They will summarize, they will include all the high quality randomized trials or cohort and the high quality systematic reviews, and then they will do critical appraisal, and then they will write recommendations according to the level of evidence. And I will show you some example in a second. It's very important to appreciate that this is not a cookbook, but it's guidance to improve, a guidance for healthcare providers to apply in the practice. But as we mentioned in the first couple of slides, that any clinical practice guidelines or evidence-based in general need to be adapted to your resources, need to be adapted to the clinical settings and the clinical circumstances, and all of that coupled with the clinical expertise of the practitioner. This is an example, a screenshot of UpToDate, and the beauty of UpToDate is all of the statements, usually at the end of the chapter, the summary and recommendations, it's linked with the grade of recommendation. So there is an evidence-based recommendation, and there is a grading for that recommendation to show you how strong is the recommendation. Each journal have their own recommendation grading system. UpToDate, you can go to UpToDate and visit their website and see their recommendation system. I will take you now through the clinical practice guidelines. In the past, we had a great website, was called guidelines.gov, and basically it was a clearinghouse. It was a database of all clinical practice guidelines, but the funding for that website was stopped, and now it's not updated anymore. The alternative to that is the GIN, the Guidelines International Network, and they are picking up, and now more clinical practice guidelines are included in this database. So I searched in that database back pain, and I found 46 clinical practice guidelines. Okay, the one relevant is published 2 years ago, Non-Invasive Treatment of Acute, Subacute, and Chronic Lower Back Pain, a clinical practice guidelines from the American College of Physicians. So this is an example of how clinical practice guidelines looks like, and this is how their summary recommendation. They will have a recommendation, they will have a statement, and then at the end of each phrase, they will add moderate quality evidence, or low quality evidence, or high quality evidence, and then they will add the strength of recommendation. So if let's read recommendation 1, given that most patients with acute or subacute low back pain improve over time regardless of treatment, clinicians and patients should select non-pharmacological treatment with superficial heat, that's moderate quality evidence, massage, acupuncture, or spinal manipulation, that's low quality evidence. And then they add, if pharmacological treatment is desired, clinicians and patients should select non-steroidal anti-inflammatory drugs or skeletal muscle relaxant, that's a moderate quality evidence. And the grade of recommendation is strong recommendation. Almost universally, all clinical practice guidelines using this same style of telling you a statement, what do they recommend, how strong is the evidence, and how strong is their recommendation, is strong or weak, or and they use the grade, the guide collaboration framework. Some clinical practice guidelines, like this one published in 2007, they have attached as well pathways, clinical pathways that will help you to implement these guidelines in practice. Now, the logical question would be, are all guidelines of good quality? The logical answer would be definitely no. You can find some guidelines that are not evidence-based, they are consensus, so a group of people, 5, 10 people sitting together and they're coming up with what they call it clinical guidelines, clinical practice guidelines, but they are not evidence-based clinical practice guidelines. So you need to be careful when you are reading a clinical practice guideline that it's evidence-based practice. Now, the agreed to instrument is one of the tools available to do critical appraisal of clinical practice guidelines, but these are usually done by national entities. For example, societies, they will go find what are the available clinical practice guidelines, and then they will evaluate the different clinical practice guidelines, and then according to the assessment of the quality, they will combine them together, and then they will come up with what do we call the adaptation, not the adoption, the adaptation of clinical practice guidelines. So you don't need to worry about this critical appraisal of clinical practice guidelines, because this is usually done at the national level by independent entities. What I recommend that you focus on the critical appraisal on systematic reviews. So the take-home message, number 1, is, as you have seen here, what I recommend, if you have a question, a clinical question, you go from the top to bottom of the 6S model. If you are in a hospital that has a computerized decision support systems, that's the ideal situation. But that computer decision support system is usually built on evidence-based clinical practice guidelines. And ideally, that should be nationally adapted to reflect the practice in the country you're in. If your question, you cannot find the clinical practice guidelines, or if the clinical practice guidelines was published more than 5 years ago, or if you know for sure that there are more recent studies have been published, then I would recommend you go with the systematic reviews. If there are none, then you have no other options except to go down to the randomized controlled trials, and then you need to do the critical appraisal, maybe ask the help of someone to help you with the critical appraisal as well. Now, this is a summary. This table is a summary of a phrase that we have used, the acute low back pain phrase. As I mentioned earlier, it's a very broad phrase, and we don't usually use a similar very broad phrase when we are looking for because it's not a PICA question, it's only a presentation. There's no intervention, there's no control, there's nothing. But I've put it here hopefully as a convincing example that using Google or Google Scholar in finding evidence-based practice answers, it's very demanding and it's very not practical. And this table as well will show you the importance of the clinical queries and how helpful. If you only use PubMed, it will get you 3,000 plus search results. If you use clinical queries with the systematic reviews, for example, that will give you 140, which is very manageable. You can read 140 titles and then select what's relevant for you. Now I've finished the webinar, but what I wanted to highlight in 2 minutes only, what has the Saudi Spine Society done to promote evidence-based spine practice so far? And as we are completing or finalizing the first round of the board of directors, we're looking forward that the second board of directors will carry on this institutional plans that has started. With the initiation of the Saudi Spine Society, there was the research committee started, and this is their email if you are interested in communicating with them. It's led by Dr. Hana Sibayil. She's a consultant physical therapist, an associate professor at King Saud University. And this is their strategic plan. They have done a great job in announcing for research grants for the past 2 years. Each grant is around 20,000 each year. They announced for a total of 60,000 riyals. And every year as well in the annual conference, there are research awards that are distributed to presenters according to an independent judging committee. Now, one of the initiatives of the research committee is to start a task force for the clinical practice guidelines. That was started back in October. They have a great 27 plus report for their task force that was presented to the board of directors, and the board of directors recommended the establishment of a clinical practice guidelines committee at the Saudi Spine Society. It's almost a year old now. The clinical practice guidelines committee, again, is led by a volunteer, Dr. Zulfa Reyes. She's a national expert in clinical practice guidelines adaptation. She's an assistant, she's a consultant family physician. And the committee consists of a multidisciplinary group. There are orthopedic surgeons, neurosurgeons, physical therapists, consultant, radiologist, anesthesiologist. It's a real multidisciplinary group, and rehabilitation and physical medicine physicians. And they plan to adopt the Saudi Arabian Handbook for Health Guidelines Manual, and that would be the methodology that they will be adopting. And that this methodology is based on the guide collaboration. They have as well published a website, a page on the website, the saudispine.org/clinical guidelines, where you can go and visit some of the guidelines posted there, and they are adopted right now as is. These guidelines are the North American Spine Society guidelines that have been adopted by the Saudi Spine Society for the moment, while they are working on the adaptation process. To hear more about this, I would recommend that you watch this video where you can find it on that page. There are future plans by the Saudi Spine Society. There will be online evidence-based course done by the CPD Committee in collaboration with NAS. There will be a clinical practice guidelines course for invited and selected people who really showed interest in the first online course. And then they will kick off the clinical practice guidelines adaptation project with a couple of guidelines. This is my last slide, and this is conclude what the Saudi Spine Society is thinking in terms of the national spine care improvement ecosystem. You see at the top of the slide here, clinical practice guidelines committee, and that's usually established what's the national standard of spine care in Saudi Arabia, and that feeds into Saudi Spine Registry, which is another project to be done by the Saudi Spine Society. That feeds into the research committee to study, is there a gap between the clinical practice guidelines and what we are doing in real life? And that feeds into the patient safety committee, and all of them feeds into the board of directors, and then we'll have either to develop more continuous professional development programs or do more health promotion activities or communicate with the decision makers. We invite all of you who are interested in joining these activities to volunteer with us, the Saudi Spine Society, either in the research or in the clinical practice guidelines or any other activities. There are endless opportunities or activities to join the Saudi Spine Societies, regardless of your disciplines or background. You are all welcome, and we are all excited to have you. So to summarize, we have defined the evidence-based practice. We highlighted and emphasized that evidence-based practice is not only research evidence. It must encompass patient preferences, clinical settings, your current resources, your clinical expertise. All of that is evidence-based practice, not only research evidence. We know why it's important because we have lots of publications. We are moving towards value-based healthcare. So that's why we need to be aware of the principles of evidence-based practice. We've talked about the 5A. You ask, you acquire, you appraise, then you apply, and then you act accordingly. We've talked about the 6S model, and highly recommend that you start practicing and trying doing a critical appraisal of systematic reviews. And then the final thing, I've showed you a couple of examples of how clinical queries can really save you lots of time searching if you use the available technology that will save from 150 million search results on Google to 140 search results on clinical queries using the systematic review results. So with that, I conclude my presentation and webinar, and thank you again for listening, and looking forward for your questions and inputs, and I'll leave the mic for Dr. Khaled Alassiri.
Thank you so much, Dr. Sohail, for this excellent and informative presentation. And now we can take the question. Until now, I just have one question on the messages, and some hands is raised for the question. So maybe we'll make it as a we'll start with the first one on the messages. A question from, I think, Dr. Riyadh. But I think I'll give him the microphone. It's the only message, if you don't mind. Yeah. Okay, I'm just checking on the questions for a minute. Please, if you have any questions, just raise your hand. We have still about 8 to 10 minutes to close the session. So if you have any question, please do so. I cannot see Dr. Riyadh. He was raising his hand, but I lost him. So I'll just give you the question directly, Dr. Sohail. I cannot find him in the. I hope he's still there. Anyway. So nice presentation, Dr. Sohail. This is his word. Is up-to-date superior to the clinical key or dynamite in evidence-based spine care? If so, what is the abundant by our hospital, King Fahad, I think KFHD, who is taking decision to choose a medical database over another? Who chose the decision?
So the question is, the question is up to date, which is better, Dynamed or up to date or clinical key? Or up to date is the most comprehensive one, I would say, and it's the oldest in the market, but it's more oriented towards lots of content are medically oriented. There are few surgically oriented content. There are different similar resources. Again, in 45 minutes, I cannot go over all the resources. I tried really to pick, as I mentioned, the critical appraisal worksheets. There are different kinds of them. Similarly, the secondary sources, I said, example, the evidence-based, the textbook, one of the examples up to date. Clinical key is another example, but the question is who decide what? That depends on each hospital. Some hospital would have a committee of different healthcare providers, like representation from physicians, from nurses, from physical therapists and technicians, and all the relevant specialties. And usually those committees will decide what's appropriate databases. Other hospital decisions will be made by the librarian or by there are different methods. I don't have the evidence-based recommendation for which method, but I think it makes sense to involve the stakeholders, the recipients in this decision making, who are the frontline healthcare providers. Okay, Dr. Khaled?
Yes, it's okay. Another question. I'm just reading it, just a couple of seconds. There's a question from Amira Arti. She said, thank you so much, doctor. The Spine Society, I just want to ask about the first S, I think systematic review is written, it's only S, system computerized. Is this applied in our hospitals? I think she's mentioning the systematic review computerized one.
Yeah, the computerized decision support system, there are many big systems. I don't like to specify the trade names of the systems, but there are many health information system, or HIS, that have built-in computerized decision support facilities or features. It is available in the market, yeah, but they are very expensive.
Good. Now there is no more written question. I'm just seeing only here one hand. I think Bashir Rashid. I'll give her the microphone if she can direct ask the question to Dr. Sohail.
Okay.
Dr. Bashir, you can ask if you. Dr. Bashir, you are on the mic if you want to ask. No response. You keep raising your hand, so I just unmute you and you can speak. Okay. I hope you're not forgetting the hand raise only. If any one of the attendants has still a question, we have only around 3 minutes to close the session. It's an excellent talk, Dr. Sohail. I think it's clear and you mentioned everything, so no more question. I think it's coming to me. Although, mashallah, we have a lot of attendance to your webinar.
I was looking there, 80 plus 85, I think, for the.
It's reaching 80 now. Mashallah.
Any questions? You can raise your hand. There is a button there to raise your hand to ask questions.
Yeah, now I think Dr. Riyadh is raising his hand. I'll give you the microphone, Dr. Riyadh. Okay. I'll give you the mic now. Please proceed.
Hello. Are you hearing me?
Fadal, Dr. Riyadh.
You are hearing me? Dr. Sohail, Assalamu alaikum.
Alaikum salam.
Thank
you first of all for your nice presentation. I'd like to ask another question. To make an appraisal about our current situation, to which extent are we implementing clinical practice guidelines in the spinal care?
So sorry, I couldn't hear the question clearly. To which extent?
Yes. To which extent are we implementing clinical practice guidelines in our daily spinal care? Your thought about this? Are we really implementing the clinical practice guidelines in our hospitals or all our hospitals? Are we following the guidelines or not, according to you?
Okay. So if I understand it,
what you've seen in our hospital, in another hospital, what do you think? And if not, or if it is only partially, why don't we implement those clinical practice guidelines? What to do to go through the clinical practice guidelines?
Okay, that's a great question. That's a great question. Thank you, Dr. Riyad. Actually, there is a book called Barriers to Evidence Implementation. And we know clinical practice guidelines, they are published, and that's, we say that the development of the clinical practice guidelines. But what's more challenging is the clinical practice guidelines implementation, okay? And there is a whole science called the implementation science, a whole science called implementation science. So it's not only in our hospitals and other hospitals, so all over the world, there are challenges in implementing clinical practice guidelines. And the well-designed clinical practice guidelines, they would usually put what are the potential barriers for implementation. They will put it there in the clinical practice guidelines, and then they will promote research to research what's the percentage of guideline implementation. Are we fully implementing them? Are we 50% implementing them? And this is where, if we go to our first slide, the previous slide, where I showed you can you see my slide here? Where I showed you the ecosystem of the Saudi Patient Safety, the Saudi Spine Society. This is our ecosystem. We are hoping that when we are doing clinical practice guidelines, and then we are collecting data through the society in the registry, and we'll see where is the problem in the defect in the clinical practice guidelines. That goes through the research committee, and then the board of directors will recommend doing more courses, or will recommend doing more health promotion, or will recommend some recommendation to decision makers to make some of the resources available, or any changes required to implement the clinical practice guidelines. So our eventual goal is to improve quality, improve safety, and the cost effectiveness, efficiency, all of that through the implementation of clinical practice guidelines and coupling that with the registry. I hope that answered your question, but this is the 1 million riyal or 10 million riyal question. It's very challenging, and there are journals called the implementation science journals on that.
One more question, Dr. Sohail, coming from Dr. Khaled Alassiri. Any suggestion to help application and implementation of the hospital and the national CPD?
Sorry, what's the beginning of the question?
Any suggestions to help application and implementation of the hospitals and the national CPGs? Any suggestions?
Okay. Well, I would like to thank Dr. Khaled Saleh. He was the chair of the research committee when we started. Then he apologized. He got the commitments. So I'd like to thank him online. The recommendation for the implementation, there is a book published by the Institute of Medicine. It's called Guidelines That We Trust, or Trustworthy Guidelines. And that includes recommendation for developing guidelines and recommendation for implementing and uptake of guidelines. There are multiple recommendations, for example, including different stakeholders in the development, in the planning and development phase. Presenting, in addition to the very comprehensive big guidelines, because some guidelines are 100 pages, 120 pages, they recommend as well to have a user-friendly version, which is 10, 15 pages. There are recommendations of having a patient a patient version of the guidelines, the layperson version in the local language, like in Arabic, for example, to have a layperson version of the guidelines in Arabic, that will increase the implementation. To have infographics, to have all of that. Actually, the Clinical Practice Guidelines Committee of the Saudi Spine Society is planning to do once we start, once they start the process of the adaptation. But there are recommendations out there. There are international recommendation of that you can do to increase the uptake. Awareness, CPD programs, all of that. These are different methods of clinical practice guidelines implementation and dissemination.
Okay, one more question, Dr. Sohail. Sorry, I don't have the name. Maybe it's not so clear, but one of the audience is asking. His name is not appearing on the list. So, but the question is: do the Saudi Spine Society has structured program for improving in residents cognitive and technical ABM skills?
Does the Saudi Spine Society do what? Sorry, I didn't hear it.
Do the Saudi Spine Society have a structured program for improving in residents cognitive and technical ABM skills? I think you mentioned that in the presentation. Maybe he missed it.
Okay, for the residents, the question
for the ABM skills, technically and cognitive.
Yeah, I mean, this is one of the courses. This is one of the initiatives by the Saudi Spine Society, and mashallah, we have a very active CPD committee that we cannot keep track of the activity of Dr. Khaled Alassiri. This is one, and there will be another online course on EBM, and that will be over a month period, collaborating with the North American Spine Society. There will be face-to-face workshops for clinical practice guidelines. In addition to other available guidelines in Saudi, we don't want to reinvent the wheel. If there are other clinical practice, if there are others workshops that have been done, then it's there. We don't need to reinvent. What we are trying to do here is coming up with programs that are missing from in the Saudi healthcare, for the Saudi healthcare system. I hope that answered it. Maybe Dr. Khaled, I will just go to this to answer the question of Dr. Khaled Al-Saleh regarding the dissemination and promoting the implementation. This slide showed you in the dissemination, they have plans for the long, short, public version, infographic, video, conference presentation, awareness days, all of these, the awareness about the CPGs. And then to promote the implementation, they have initially, whenever you publish a guidelines, it's recommended to put what are the key performance indicators that people need to follow to see whether you have successfully implemented guidelines or not. It's recommended to have clinical pathways as well attached to it. It's recommended to have research grants on studying how much the country have implemented guidelines and the disseminate and the success of that implementation. So these are strategies and actions and plans that the great Clinical Practice Guidelines Committee under the leadership of Dr. Zulfa Reyes and more than 10 members have done and created a marvelous job in doing this strategy.
Just to add, Dr. Zahir, from the CPD side, I mean, we are working hardly now, and we know that the evidence-based practice is the cornerstone to start anything in the clinical practice guidelines, and we'll try actually to build people as an appraisal. And we have a lot of connection with the North American Spine Society and other even people who had experience in the clinical practice guidelines to build our base in Saudi Arabia to move to the adaptation period. So we are planning, and inshallah we have a good courses involve everybody in the evidence-based medicine, and even we are preparing a lot of people who have the interest to join even the open committee, which is the clinical practice guidelines. Is actually an open committee, and Dr. Sohail knows that everybody is welcome to join. Everybody is if you have the interest, I mean, it's an open door for everybody.
Excellent.
There is, I think we can have another question. Maybe it's the last one. No more question is written. I'll give you, Dr. Ala, the mic to. He's raising hand for a long time, so the mic is yours. Dr. Ala? Dr. Ala, the mic is open for you if you want to ask your question. So if there is no more question, I think Dr. Sohail is going to conclude. We are exactly 5 minutes away of the time. It was a wonderful presentation, full informative. I enjoyed myself, and I have a lot of positive in the chatting message that they are happy, and they are all of them give a huge positive feedback for this. There is more than one recommendation to continue doing this webinar, and as we said, this is the first time we launched the webinar. Inshallah, it will continue with more of scientific program and even administrative and skill building programs. I want to thank all of the attendees with us in this fantastic evening. So many thanks for you, Dr. Sohail, to give us this great talk. If you had anything to say before we conclude, you are welcome.
Truly, I just want to conclude with it's great to be with the Saudi Spine Society, really. And everybody's working very hard, day and night, and all of the CPD committees, CPG committees, all of these are busy clinicians, busy surgeons, busy physicians, busy physical therapists, the board of directors. Everyone is volunteering their time. And I think doing some of these webinars and having this attendance up to, at one point I've seen more than 85 for the first webinar. I think this is an indication of how the CPD really have thought out of the box in coming up with these new tool of continuous professional development, and understand that the Public Education Committee as well will be doing similar webinars for health promotion in Arabic. So it's really an honor to be with the Saudi Spine Society, and I would just conclude that thank you a million for all of the 85 people who joined us in this webinar, and you receive a questionnaire or a survey after the webinar, probably tomorrow, to evaluate this experience, because this is the first experience by the Saudi Spine Society, and I assure you that the president of the society, Dr. Sohail Isa, will be evaluating those and seeing how good or how bad we did, and to continuously improve our webinars in the future. And if you have any suggestions, please don't hesitate to contact me. I had my LinkedIn profile at the beginning, or to contact the society through info@Saudi Spine Society, saudispine.org, or any of the other committees mentioned their emails here. Thank you very much. Thank you, Dr. Khaled, for your time and your leadership and your great dedication to making continuous professional development committee. It's the star committee of all the Saudi Spine Society.
Thank you so much for all, and have a nice meeting. And see you inshallah in the next webinar. Assalamu alaikum wa rahmatullahi wa barakatuh.
Assalamu alaikum.